Sobrin is going up next. Lucia, I met Lucia back in 2002, I think, in Mass, first time at Mass INDR. And she's professor at Harvard University in Mass INDR, Retina and Uveitis Service. And she's going to talk, to deliver her talk on autoimmune retinopathy diagnosis and treatment.
Thank you, Sophia. Thank you for the invitation. Thank you to the organizers for this opportunity to speak to you all about autoimmune retinopathy diagnosis and treatment. I wish I could be with you in person in Greece, but I'm glad we have this time virtually as well. I have no financial interests or relationships to disclose. So I'll talk about the challenges in autoimmune retinopathy, the challenges in diagnosis, in particular the pitfalls of anti-retinal antibody testing and the importance of ruling out other mimicking diseases, in particular the importance of the role of genetic testing. And then we'll talk about challenges in treatment, including the different treatment options and how we can best evaluate how these patients are responding to treatment. Autoimmune retinopathy is an inflammation-mediated retinopathy manifested by ERG depression. Common symptoms are nyctalopia, scotomas, decreased vision, and positive visual phenomenon. The examination is often unremarkable, which leads this diagnosis often to be delayed. In 2014, there was a Delphi paper published where the essential criteria that were agreed on for diagnosis were an abnormality in ERG findings with or without visual field abnormality, positive anti-retinal antibodies, and no evidence of degenerative eye disease such as retinitis pigmentosa. And we'll delve into each of these criteria a bit. It's important first to remember that there are different types of AIR. There is AIR that's associated with a neoplasm, so cancer-associated retinopathy or CAR, and melanoma-associated retinopathy or MAR. And then there's non-paraneoplastic AIR. And finally, sometimes the retinopathy comes associated with optic neuropathy, and we term that ARIN. These diseases are caused depending on the underlying status in terms of cancer. In CAR and MAR, we believe it's molecular mimicry between tumor antigens and retinal proteins. And in non-paraneoplastic AIR, we're not sure, but we think there's either cross-reaction between retinal proteins and unknown antigens. Some of these may be infectious, or potentially there could be malignancy that's regressed and no longer detectable, but still the instigator of the antibodies. So the primary issue I think that most of us struggle with is the anti-retinal antibodies in the diagnosis of AIR. And although it is part of the essential criteria that was decided upon by the Delphi group, I think over time, the field has moved away from relying on anti-retinal antibodies. And the reason for this is that the pathogenicity of these antibodies, apart from recoverant, is not well established. And recently there was an excellent paper where they sent blood on patients who did not have AIR for anti-retinal antibody testing. And of these patients, 93% had anti-retinal antibodies. So this means that this test has a specificity of 7%. And such a low specificity test really is not of much help. In the real world, many uveitis specialists do not even order anti-retinal antibodies anymore and really make a diagnosis based on the clinical findings and exclusion of other diseases. We also know that these antibodies, in terms of their testing, are not standardized or reproducible. When we sent blood on our patients to do different laboratories, only 60% of the time did they agree on whether antibody was present, yes, no. And then in terms of identifying the same antibody, they only identified the same antibody 36% of the time. So you can see why a reliance on anti-retinal antibodies is very problematic. So we can't rely on them as diagnostic tests. What can we rely on? Well, first is the clinical findings, visual symptoms, unexplained ERG depression. If you have a patient with this picture, an AIR, it needs to be a diagnosis of exclusion. What do you need to exclude? Retinal toxicity from medications is an important thing to exclude. This is especially true in a patient where you're considering CAR, where they may have received prior chemotherapy, which may be retinal toxic. And here it's more the temporal association of the onset of symptoms that helps to make the diagnosis. I've seen vitamin A deficiency being missed and misdiagnosed as AIR. So making sure the patient is not at risk, for example, by having had bariatric surgery for having this problem. The big one is inherited retinal degenerations, and I'll talk about genetic testing in a moment. But the other important thing is to really rule out occult posterior uveitis. And for my patients, they get fluorescein angiography and indocyanine green angiography to make sure that there are no subtle signs that are missed on exam, that this is really just uveitis and not autoimmune retinopathy. So as I mentioned, the big issue is trying to distinguish AIR from inherited retinal degeneration. Clinically, there are things that can help us distinguish to a certain degree. AIR usually has more sudden onset of symptoms. The patients don't have a history of retinal degeneration. The two eyes can be asymmetric in their involvement, and there's typically no pigment deposition, at least earlier on in the course of disease. In contrast, inherited retinal degenerations typically have a slower onset of symptoms. Some, but not all patients, will have a family history of retinal degeneration. It will tend to be more symmetric and tend to have more prominent pigment deposition. But none of these are hard and fast for distinguishing these two entities. So often we're still in the conundrum whether a patient can just have, maybe just has an inherited retinal degeneration and not AIR. So here's where genetic testing has really helped us. And we get genetic testing on all patients in whom we suspect AIR. The role of genetic testing is, and the helpfulness of genetic testing, I should say, depends on the result. So if it's positive, that's extremely helpful. It confirms that there's inherited retinal degeneration, the patient avoids unnecessary anti-inflammatory and immunosuppressive treatment, and they may be eventually eligible for therapies specific to their mutations. If it's negative, it's not very helpful. It's important to always talk to patients about the fact that the panels we have nowadays, while quite good, do not have all the possible mutations that a patient with an inherited retinal degeneration might have. And so it's still possible that the patient has an inherited retinal degeneration that is caused by a mutation that's not part of the panel or not even known yet. And we have reported on the predictive value of genetic testing in this patient population. And here's an illustrative example of the importance of genetic testing. So this was a 41-year-old woman that I saw who had a 10-year history of being diagnosed with ocular migraine and then big blind spot syndrome because of paracentral scotomas. She did not have any history of retinal degeneration. You can see that there's, from this exam, is relatively normal, maybe mild pigmentary changes in the periphery, but nothing striking. The autofluorescence is more striking. You can see this hyper-autofluorescent ring, also some hypo-autofluorescent changes around the nerve and the arcades. You can see her paracentral scotomas here, and her ERGs were decreased. In particular, scotopic amplitudes were down 50%. And anti-retinal antibodies had been sent on her, and they were present. In addition to the Western blot, the immunohistochemical staining showed that the photoreceptors, inner plexiform, and nerve fiber layers had staining. And so she was hoping to have autoimmune retinopathy because that's a treatable condition. But we first got genetic testing. And what this patient had was Usher syndrome-related inherited retinal degeneration or mutation in the Usher2A gene. And so it was really important. Here's a patient who didn't have a diagnosis for 10 years, and genetic testing, because it had evolved over that time, finally brought her diagnosis to the fore and also had her avoid immunosuppressive therapy. So it's also important that once you've gone through all the painstaking work of excluding other things and you've decided that the patient has AIR, you need to rule out an occult malignancy. This is because half of CAR patients present with visual symptoms prior to the diagnosis of their cancer, although CAR has been documented up to 10 years after the diagnosis of cancer. Small cell cancer is the most common one, but other common cancers are gynecologic, urologic, and endocrine tumors. And if there's no known cancer, it's really important to communicate with the primary care physician to examine for an underlying malignancy. We typically recommend a PET-CT skull base to pelvis and an MRI brain. So now you've diagnosed the patient and ruled out cancer. How about treatment? So many things have been tried with variable success. I've listed here all of them. The most common one is immunosuppression, either with steroids or more conventional agents, and even now some biologics. Plasmapheresis can be tried acutely, but plasmapheresis is very transient and is not really a great long-term therapy. Intravenous immunoglobulin has reported to be useful for certain patients, and the mechanism is by blocking pathogenic antibodies. And rituximab has also been used because it selectively impairs B cell function. So I'll concentrate on the biologics because there's been some more recent reports about their use. So in particular, the two IL-6 inhibitors, tocilizumab and saralimumab, have been shown to be potentially useful in two case reports. In one patient with AIR, tocilizumab led to reconstitution of ellipsoid zone. And in one patient with AIR and macular edema, saralimumab led to the resolution of that edema. We have studied rituximab more extensively and found that it leads to stability or improvement in a majority of AIR patients, and I'll share that data with you. So we had 16 patients, of which 7 had CAR and 9 had non-paraneoplastic autoimmune retinopathy, and we followed them after their rituximab initiation for a mean of 16.7 months. 13 patients had been treated with prior immunosuppression, and 3 had been treatment naive before starting Rituxan. And we looked at their visual acuity and their full field ERG as well as OCT to determine whether or not they responded. And we had very conservative thresholds for improvement, with 40% plus or minus being the threshold for ERG. In terms of vision, at the last follow-up compared to before rituximab initiation, 40% of eyes had improvement, 63% were stable, and 23% worsened despite the treatment. In terms of ERG outcomes at the last follow-up, 25% of eyes had extinguished ERG at baseline and were excluded because they couldn't improve. The remainder of eyes had stable ERG parameters over the period of treatment. And we did not see any significant changes in the OCT volume or thickness with rituximab. Just want to show a couple of illustrative cases of patients who improved. So this is a 69-year-old woman with non-paraneoplastic AIR. She was treated initially with steroids, which didn't really help her significantly in terms of her symptoms. Then we gave her rituximab in the dose shown here weekly for 4 weeks. And what you see is that her vision improved significantly 6 months after receiving rituximab, and she also had some improvement in some of the ERG parameters, particularly the bright scotopic amplitude. The second case I'll show is a 23-year-old woman also with non-paraneoplastic AIR. She had been treated initially with CellCept without much improvement, and then we treated her with the same regimen as the prior patient with rituximab. And what you see here is a charting of her visual acuity. So when she presented and she was getting worse, she took CellCept and worsened further, and then started rituximab, and over the ensuing months improved. This was the same trend in the left eye. And so in our general approach to treatment for patients with AIR, acutely we use steroids. Typically we initiate Rituxan as soon as possible after that, and we use Rituxan and IVIG on a maintenance basis, generally speaking. Although, all of the agents that previously mentioned can be used in particular cases. Some special treatment considerations in CAR and MAR. Sometimes we get asked, what if we treat the underlying malignancy, which would potentially decrease the levels of circulating anti-retinal antibodies, because if you reduce the tumor cell burden, the antigen is gone. It's not clear, at least it's not consistent in our clinical experience, that the treatment of the malignancy affects the CAR or MAR course. So we usually treat in addition to this. The other issue with treating CAR and MAR with immunosuppressive therapy is that you also may suppress the immune system's attempts to control the cancer. And so this is always a conversation with the oncologist. Almost never are the oncologists against treatment. We note often that some of the therapies we use are actually used at higher doses for cancer, and so are not particularly problematic. And there are many case reports of CAR treatment with these agents without deleterious effects on cancer control. How do we know they're getting better? Well, we follow visual acuity, visual field, OCT, and ERG primarily. Anti-retinal antibodies, as with diagnosis, are problematic for following patients. We looked at 15 AIR patients, including 5 with CAR and 1 with MAR, and we could find no association between their serial anti-retinal antibody levels and their visual acuity, OCT, or ERG parameters, and so we do not do serial anti-retinal antibodies. So in summary, AIR is a diagnosis of exclusion. It's important to avoid over-reliance on anti-retinal antibody results when making this diagnosis. It's more important to investigate alternative causes thoroughly and to strongly consider genetic testing in the great majority of cases. A malignancy workup should always be performed once the AIR diagnosis is confirmed. And treatment may require trials of several agents with steroids, both local and systemic, rituximab and IVIG having the most efficacy in our experience. Thank you very much.
Thank you so much, Lucia, for this very interesting and excellent talk. So in case you have a patient that you suspect that you have an AIR, but there is no underlying malignancy, no underlying, you don't find any malignancy, would you go and jump into immunosuppression? I mean, it's a tricky question because these drugs are used for cancer also, but I mean, sometimes you might get into malpractice issues, and sometimes you cannot persuade the patient that if a cancer comes up 5 years later, that is not a direct effect of the treatment, of the IMT treatment. I mean, what are your thoughts on this?
Yeah, so there are patients that are rapidly losing vision when you catch them early. And for them, it's very easy to convince them to do the treatment. And before we do the treatment, usually we start steroids because in a patient that's rapidly progressive, we want to quench the disease. But we're also initiating the cancer workup immediately, like as I mentioned, a CAT scan of the whole body, PET scan to make sure there's nothing there. And so for those patients, I think it's clear we want to limit the damage and we want to immunosuppress them. And I have a very clear conversation with them. Even if all the cancer screening comes back, you could have an underlying cancer. There's a small risk that we are going to unmask your cancer by immunosuppressing. But in the patients who are rapidly losing vision, it's typically an easy choice. Sometimes we get patients that are a little longer into their course and they're a little bit burnt out. So they probably lost a lot of function and it's unclear they're going to gain much function. There, the conversation and the convincing of the patient takes a little bit longer, but the conversation is the same. Rule out malignancy. We think we can prevent further loss. You've already lost some and you may never regain that. And there's a small risk again that we could unmask your cancer, but there's a real risk to your vision if you don't get treated.
Thank you. Are there any questions, comments?
I have a comment. Thank you for your information. And I would like to emphasize the need of exploration for a small cell carcinoma concerning your data, because small cell carcinoma has the property to give metastasis to the choroid and to the brain in the same time, earlier than its clinical presence or detection by imaging, even years earlier.
Okay.
That's right.
Just a short question. Do you have any experience or have you tried intravitreal rituximab in our cases?
I have never tried that. Okay. No, I have not tried intravitreal rituximab. I've used it for lymphoma only.
Thanks.
It's a very interesting thought. It clears very rapidly is one issue with rituximab, potentially, but it's a very interesting idea.
I think that if you're going to use a rituximab, it would be best if you use it intravenously. And in fact, nowadays, when I have a patient that once I decided is an AIR patient, I use very aggressively a combination of immunoglobulin plus rituximab plus metoprenisolone to do it, because I have learned that if we do it very aggressively, at times I'm more successful. But again, this raised to the point that Lucia mentioned before. I think that to us, we should think of anti-retinal antibody just like another marker. For example, there are many patients with HLA-B27 positivity, but we do not take all of them and treat them for the uveitis. Same thing with this concept. When we make the diagnosis of AIR, like Lucia, I fully agree, it should be a diagnosis of occlusion, and we have to make sure we have other things, but also we don't treat the lab result. I treat only when I see that there's evidence of progression of disease. So the first time that go in it, we look at it and we see whether there's any difference and then you follow the patient with multiple parameter, ERG, visual field, adaptive optic, different way to look at that. Only when you actually see progression, then I start to discuss about treatment with them, of course, rule out malignancy and other things. So I myself still do testing for both anti-retinal antibody as well for genetic testing. But like I said, I don't treat the lab. I treat when I see there's progression of disease or there's definitely in that. So I think that way the patient and you can appreciate what are we treating for and whether or not the risk and benefit can parallel each other.
Thank you so much, Juan, for your comment.